or from the first 3 millimeters of the LAD or circumflex. Intravascular imaging is very important into understanding the anatomy sometimes, because as you could see, when you were talking about differences of 3 millimeters, sometimes the projections makes it look like a real bifurcation. Left main disease is usually defined as a proximal LAD or distal main branch, let's say proximal left main, distal main branch, or the LAD with a stenosis more than 50 within the 5 millimeters from the carina, or with a 50% stenosis in the side branches, ramus, circumflex, that have at least a diameter of more than 2.25. Now, as I said, from the all left mains, the prevalence of a real left main disease, a left main trifurcation, is 10 to 15%. So we're talking to 10 to 15% of something that is about already has a low prevalence of 5%. So as I said, it's not always the ramus not always starting from the left main, but could also start from the first 3 millimeters of the LAD or circumflex. We could use the Medina classification for this, and in the Medina classification is still the most used, I think. You could say that we talk always we start in this order, so we have the main proximal branch, that's the left main, then we talk to the distal LAD, and then again circumflex and ramus in this order. There are other classifications about this, and now Medina already told, there is the Shamas classification. Another interesting classification is the Ludwig classification, where he uses letters, and the letters are, first of all, put there if there is a stenosis of more than 70% of this branch. So in this bifurcation that is shown here, you have a B, and a small d, and the d is small if the vessel is less than 3.5 millimeters. Now, there is a lot of theory over the angles and the flow and so on, but I think to make this easy, one thing is very interesting, that when we're talking for a real bifurcation, the angle between the circumflex and the LAD is on average very, very close to 90 degrees. And that is very important because that makes splitting of the treatment, I'll show you in the next slides, you can split this treatment from a trifurcation in two types of bifurcation treatment. Now, it is important to show also that, let's say it's first of all, that left main trifurcation, a real left main trifurcation, even if we accept that there is no disease in the rest of the coronary disease out of the trifurcation, still is associated with a high syntax score and therefore is, in principle, let's say, surgical territory. But there are also reasons why we sometimes could do PCI for this. And sometimes there are patients with CABG contraindications, patients that are old, patients, sometimes it's just the patient's choice, they don't want to have a CABG. Sometimes it's the urgent treatments. And let's face it, we're having less and less surgeons around. So a lot of centers, they don't even have a cardiac surgeon anymore. So in this situation, this is where we're getting more and more of these cases also because the patients are getting older. Anyway, let me be clear. All the available data is in favor of surgery. However, in the Excel study, we have some data that similar results could be achieved in trifurcation as with bifurcation. Now, PCI outcomes are related to the lesion complexity, and the lesion complexity is related to the stenting outcomes, of course. So the number of truly diseased side branches, the amount of calcification, the distribution of the calcification, but as well as of the fibroaderoma, so the lipidic plaque eventually, the angle of those vessels are all factors that contribute to this. However, all studies show that a left main lesion becomes more complex, the PCI is associated with worse outcomes, which makes sense for every kind of lesion. Therefore, it's important to have imaging for these procedures. Therefore, it's strongly recommended that in the left main treatment, imaging more and more should facilitate these procedures. There is also another thing that we have known from the small amount of studies that have been around. The studies are very mixed, starting from the old drug-eluting stents to studies with now the new drug-eluting stents. And the techniques used there are very different. However, there is one thing that, to make this simple, the more stents you use, the more MACE you have. So multi-stenting, the common opinion is, should be reserved for selected complex left main treatments that cannot be successfully managed by one stent only. And there is one thing that makes this treatment a bit more difficult. We come out of our normal common zone thinking of 2 dimensions into what we should now think here, thinking of 3 dimensions, and that needs some imagination. So look at this, the difference, for example, from a bifurcation and a trifurcation. There is here something that we call this angle B, and that is the angle that you have, or the inflow angle. You have it in both, but it becomes more important in the trifurcation. So to make this easy, look at this image here on the right corner of the slide, and just imagine how these 3 tubes coming to the left main. And therefore, it is important to understand that if we now are thinking of the most common technique that we have used in the bifurcations recently, and we think that we should do a double decay crush, a 3-stent technique, you could imagine that by putting 2 stents, you're going to have, and putting again a stent then over the left main, you have at a certain point an overlap of 5 layers, so there is not a go. There is another reason why these decay crush techniques, I don't like them very much into setting of the 3 left main bifurcations. Because you could see here, there are 2 parts. Let me take this. There are 2 parts here. This part here and this part here. Now this part here is what we're going to use as a dimension for our post dilation. And there is an area here that is never really covered or never really, let's say, crashed. So imagine that you're going to do a crashing there and then a pot. That is how that's going to look seen from a sagittal, view. Seen from basically, I start a real trifurcation with a predilation of the necessary where it's necessary, and then followed by intravascular imaging, and then I do stenting of the circumflex on on a T-stenting technique. Because this has a 90-degree angle. Then I continue with the mini culotte, because I explained you why I don't like to do a decay crush. Following that, I do the ramus, and then after doing the necessary kissing, I finished with a trissing and a final pot. The advantage of this technique is that it gives a well-opposed stance in all the 3 branches and the left main. Very short segment with double layer of stents. 3 avoids the 3D disadvantages of trifurcation treatment by turning it in a double bifurcation. Thank you.